Hey guys, today we're talking about pain in your hips, anterior hip pain. Very, very common thing, very common to maybe get some pinching in a deep squat. Maybe you've been told you have an impingement. Well, we're gonna cover possible causes, some mechanics of the hip, some easy interventions to maybe alleviate pain, and then some ways to maybe work on a little hip mobility. So what would be some of the possible causes? Something that you may have heard before would be called FAIS, or femoroacetabular impingement syndrome. Funny thing is, as this has become more well-known, it's become more diagnosed. That's kind of how things go. So maybe it's been, a thing the whole time, or maybe we're just over-calling it, because when we get hip pain with flexion or internal rotation, we have some docs out there in the field that are jumping right to that impingement, and then people are kind of grabbing onto that. That's a very common thing. Impingement is a real thing for some patients. So what are the types of impingement, and what is an impingement? So we know that our hip is a ball and socket joint. So there's a type of impingement called a cam impingement. A cam impingement is when the ball of your femur, the head of your femur, is ugly. It's kind of not round and congruent. So you can imagine as that kind of moves around, you may hit some sticking points. The other kind is a pincher. So imagine a piece of bone, maybe kind of a spur or a bony overgrowth around the socket or the acetabular rim. And as you move, that's going to pinch. And then you can have a combination of the two where I got an irregular femoral head, a pincher, and then they move together, and that's going to be a little nasty. Now, you can have other types of hip formations or structure. If you've heard of hip dysplasia or a flattening of the femoral head, all these things can occur that can cause hip pain. So there's a plethora of things: osteoarthritis, avascular necrosis, steroid use. These things can all lead to hip pain. Now, an impingement test to find out what kind of impingement we have is usually we're going to take the hip. If I was lying on my back and a physician took my leg passively up into hip flexion, and they may kind of scope or scrape the acetabular rim, and if we run into a bony spot, and then the clinically classic one would be taking us up past 90 degrees and taking me through internal rotation and see if I kind of get a pinch in here, or what we call the C sign of pain there. Now, the sensitivity, so a sensitive test means how easily or how often is it going to pick up the appropriate thing, or pick up a pathology, not the appropriate thing. So the sensitivity of that test is about 70%. So about 70% of the time is going to catch that, right? When we do this little internal rotation flexion. About 44% of the time it's specific. So that means only about 44% of the time is it actually impingement. So that's fairly low. So you got to think about all the other things that it could be. So what are some of those other things it could be? Could be a labrum derangement or tear. The labrum is the soft tissue or cartilaginous covering of the inside of the socket that helps kind of suction cup the femoral head in there. Kind of gives a smooth surface to slide against. Sometimes you get a pairing of an impingement and a labral tear, or I've had some type of injury to that labrum. This was a labral tear with a little bit of arterial dissection, but Beau Jackson is a really famous one. He kind of got tackled from behind, outreached, and kind of jammed his femoral head up into that labrum. He tore the artery. So later down the road, he had some avascular necrosis that we just talked about, and that took him out of sport. So hip injuries can be a big deal. You could also have a strain or sprain of the muscles around your hip, your TFL, your pectineus, even part of your quadriceps group. That can happen. I think that's more the rarity, right? Muscles are pretty robust, pretty tough. Something that we see more and more commonly in here is just nerve facilitation, or basically a nerve sensitization. So there's a lot of nerves, and we're going to look at these in a second. There's a lot of nerves going around the hip. It's a very important structure. We also got some very important bits in between the two hips. So you can imagine that your nervous system's wanting to protect this. So let's look at these real quick. So we're looking at cutaneous nerves, nerves that are responsible for sensation, and this is just some of them. We can see the iliohypogastric, the ilioinguinal, lateral femoral cutaneous. Now we have some other ones. We have genitofemoral. And then if we could flip this around so we were looking at the back, we can see these foramen in the sacrum. Well, the nerves, the sensory nerves that exit that foramen are called the superior cluneal nerves. The top ones, the bottom ones are the inferior cluneal nerves. Now these are all sensory nerves, and they can become sensitized due to altered mechanics or aberrant mechanics, right? I'm not moving quite right through my squat or my running gait, or just walking, or I'm sitting a lot. It could also be due to underlying pathology. So maybe I have a little impingement or a little labral tear that's not that bad, but my nervous system is trying to alert me to something bigger. These peripheral nerves could be the pain generator, and we're going to show you a way to desensitize those. So let's go over the mechanics of a deep squat and how the hip works, because this is where most people are going to come into an office like mine and say, man, I'm getting some hip pain in the bottom of my squat or going through a squat. So when we go down into a squat, your femur is moving into internal rotation opposed or against your pelvis. I hope that makes sense to everybody. Now, a lot of people see knees out and we would think, well, that's external rotation, but you got to think of where your pelvis is going over your femur. So again, if maybe I have some undue tightness in the adductors or the posterior chain, you can kind of pull your pelvis and femur into a poor position and create more of what we call a secondary impingement, like in the shoulder. And a secondary impingement is where I'm creating it through mechanics. Primary would be kind of from the structure itself. So if I have that kind of impingement and I move down here, let's think of how else I could create pain. Maybe it's mechanics. Maybe my squat's not great. So sometimes it's not treatment, it's coaching, right? So make the squat better and all of a sudden the pain may be better. But let's say we work on the squat. We are doing some of our clinical orthopedic testing and we're saying, let's try to rule out bigger pathology. What's something you could do at home on your own to try to play around with this? So we showed all of these sensory nerves, and they're going to be accessed at different points where they kind of traverse close to the skin. So let's pick a common one, and a really common one would be basically our iliohypogastric nerve that kind of runs through here, and genitofemoral that's going to go right down the hip crease. So let's say I get hip pain in this squat. Well, what we could do is we could grab that bunch of skin right there, and we could basically start to go through a squat. We could rotate around, right? We're trying to create movement through that kind of the underlying structures, the skin, fascia, the muscle, all these structures, right? And we may have to maybe we could do leg swings. You could be creative here, right? But if we're working on nerves on the front of the hip, we probably need to get into some sort of position or movement that's going to put a little bit of stretch strain on those. Same thing for the posterior, those cluneal nerves. If I'm going to work back here, I may grab right on the top of my glute and I may cross this leg up and do a little figure 4 sit and really try to grab that skin as I move around. And then I could retest. Is it better, same, worse? That could be an easy way to start desensitizing these nerves that are a little fired up. Now, let's say that I want to be able to get into a deep squat, but when we test our hip mobility, a really common problem that can create hip pain from a mechanical standpoint is just a lack of internal rotation, right? And we said we need that for that deep squat. So a really good drill, I'm going to grab my mic here, a really good drill to work on are transfers. So these are called like a shin box drill, but we're going to start in what's called a bear stance, right? So we're kind of a bear sit. And from this position, we're going to try to dig our heels into the ground, stay tall, and we're going to rotate. And now this trail hip is in internal rotation. Now you're going to get to see one of my limitations here. This is that good old femur that I broke, and I have a titanium rod in. So as I get back to my bear position and transition, whoo, buddy, that one is a lot tighter. You can see that. Come back and transfer, and you can see I can sit very much taller on this side. One more time, transfer, just a little bit tougher there. And I hope you guys can appreciate that. So, sum it all up. Some possible causes for anterior hip pain, some mechanics of what we need to be able to achieve a deep squat or even just a deep lunge, ways to desensitize these sensory nerves, and a really quick, easy warm-up mobility drill to work on internal rotation of your hip. Hope you guys got something out of that. I'll see you next time.